Hi, and welcome to tonight's VCU Health virtual seminar on palliative care in cancer patients. My name is Blake Belden. I'm a member of the marketing and communications team at VCU Massey Cancer Center. Tonight we are joined by Dr. Danielle Noreika, an expert in pain management and palliative care at VCU Massey Cancer Center. She will discuss how effective palliative care uses a holistic approach to improve the quality of life for cancer patients and provide specialized support for families and caregivers. Before we begin the presentation, I would just like to note that we'll hold any questions until the end. Please feel free to drop any of those questions you might have in the comment section throughout the event, and we'll address those at the end during the Q&A portion. Dr. Noreika is the Medical Director of Massey's Palliative Care Program and Associate Clinical Professor in the Division of Hematology, Oncology, and Palliative Care at the VCU School of Medicine. She also serves as the Program Director for the Hospice and Palliative Medicine Fellowship at VCU. She received her medical degree from Drexel University College of Medicine and completed her residency in internal medicine at the Naval Medical Center in Portsmouth, Virginia. After completing her residency, she remained on active duty in the U.S. Navy prior to honorable discharge after almost 10 years of service in order to pursue fellowship training in hospice and palliative medicine at VCU. Dr. Noreika has published peer-reviewed articles as well as book chapters on palliative care, quality of life, and symptom management. Her areas of focus are applying technology to palliative care and education of the future palliative physician workforce. Thank you, Dr. Noreika, for joining us. I will now turn it over to you.
Excellent. Thank you, Blake. Very much appreciated the wonderful introduction. And thank you to all of you for having me. I really appreciate the opportunity to speak with you all tonight a little bit about what I do. I know that palliative is sometimes a word that folks hear and can kind of be a little nervous about. So I really do appreciate my colleagues at Massey giving me an opportunity to tell you a little bit about what our team does and how we can kind of help our oncology colleagues in patient care. Next slide, Charnice. So you know you've picked a good career in medicine when you spend your time defining what it is that you actually do for a living. And again, I think palliative care is a term that a lot of folks hear and are not sure exactly what it means, and that can cause a lot of distress. When we describe it, though, in terms of what we actually do, it tends to be something that is very well received by not only patients, but also their loved ones. So I do have the definition up here, and I do want to highlight just a few things about what we do. First, to know that a lot of times we're actually called supportive care, and that sort of is a nod to what we do in real life. If you think about what our oncology colleagues do, and this goes for radiation oncology, surgical oncology, the treatment of cancer has become so complex and so detailed, and there's so much to consider. That's what we want their focus to be. As a palliative care doctor, I want your oncologist to completely focus on what the problem is with cancer. But we know that there's a lot outside of that cancer, that person that we're taking care of, that we want to make sure we address. And I think we're really lucky here at Massey that our oncology colleagues really have been very proactive in involving us in patient care, so that even if they don't have the time to address those things and to focus on them, that they know they're being taken care of, which is super important. So I do want to highlight from this definition, symptom management is a big thing that we do. Everyone thinks of pain, and we'll talk a little bit about pain, but there are other symptoms. And if you suffer from cancer, or you know someone who is suffering with cancer, you know that there's more to this sometimes than pain. And it's really important to be able to take those one by one, give them the focus that they deserve, and make sure we put that whole picture together. Quality of life is that focus. So it's the symptoms, but it's also how does this fit into the psychologic piece? How does it fit into the social piece? What are the supports that are needed for that person? Those are all the pieces that get added together for quality of life, and we really want to make sure we focus on how we best do that. We do practice in a team, so whenever you see a palliative care doctor, there's usually a team of folks who's working with that person: nursing, social work, psychology, chaplaincy, physical therapy, nutrition, pharmacy, and others, who all work together to help us determine what is the best plan for this person. How can we each add together our perspectives to really make a holistic plan for each patient? And I do want to also highlight that part at the end. Not only is it appropriate at any age, it's appropriate at any stage. I think there's a lot of folks who kind of think, well, you have to have maybe more of an advanced cancer to qualify for palliative care. And realistically, any patient who has cancer, no matter what the stage, realistically may need a lot of the supports I just mentioned. So we do want to make sure we take a very broad approach. And again, very grateful for our colleagues here at Massey at allowing us to do that. Next slide, Trinice. Just to give a bit of a history of our field, which I think is helpful because it kind of helps folks to understand where our field grew out of. Many folks hear the word palliative and think hospice, and we obviously have a great deal of respect for our hospice colleagues, but that's not what we do. If you look at the timeline, there was a physician who was also actually a social worker in England that started the hospice movement. And this was really kind of focused on patients who were kind of in an end of life space. But you can see over the next decades that a lot of folks started to realize, well, we have patients who are struggling with a lot, who have illnesses that cause a lot of symptoms, but we don't have a system of practice that really allows us to take care of that. I have to give credit. I don't think our surgical colleagues are recognized as much when they support palliative practices, but it was actually a surgeon that coined the term palliative. And that grew into a movement in the 1990s of saying, do we really want to just restrict this focus on quality of life for patients who might be eligible for hospice, or do we really want to make this something that's available to folks who have any sort of serious illness and make it just part of their care? And that is a movement that sort of grew over time. And you can see it's actually only in the last 15 years, so 2006, that we were formalized as a specialty. So we are a newer specialty. We're younger than a lot of the specialties that we practice with. And that means that we have a lot of opportunity to learn and grow in what we can provide for quality of life. And I do want to remember that little piece because at the end, I'm going to tell you a little bit about our clinical trials. And it really ties into sort of this history perspective where, because we're a newer specialty, there's a lot left to be learned. There's a lot of opportunities for trials, and we do want to take advantage of those. And again, very grateful to our colleagues at Massey for helping to support us being able to take those opportunities. So we'll talk a little bit more about that at the end. Next slide. Some folks ask, well, so why is it you're here in the Cancer Center? Or if I've been referred to supportive care, why is that? And I think for those of you out there who, again, have cancer yourself or have a loved one or colleague, friend who have cancer, you know some of the things that are on this slide. And you also know if you put into Google, what is it like to have cancer, some of these things that are on here are things that are going to kind of come up. These are all things that I've been told by patients over the years. And again, I don't think it's a surprise to anyone that a diagnosis of cancer and treatment of cancer produces a whole lot, not only of symptoms, but also other effects on quality of life over time. So I'll highlight a few, and I think one of the ones on here is something that everyone, it kind of occurs to everyone sort of first. Pain is something that is very feared in a cancer journey. And we certainly have seen patients who refer to us who were kind of afraid that, what if no one has the solution to my pain? What if no one knows how to get it better? But we work through those things, and a lot of those patients have very different things to say months later. But I think some of these other things that I've put on this slide might be a surprise to folks who don't have a lot of experience with cancer, that these are things that folks go through, that sort of appetite and weight are a really big deal to folks who are experiencing problems with that sometimes that we miss that opportunity to loop family members who are trusted in care into that treatment plan, that sometimes the treatment itself has side effects that we need to proactively manage in order to keep somebody at an even keel. That sometimes the little victories, like I have on here, one of the patients who came back and we were just thrilled about a trip she took, and she's like, I'm so excited if you're so excited about this trip I took because it meant a lot to me. that I was able to do it with the support of all my doctors. And it means a lot to me that you're excited about that, because other people might think it's a little thing, but we know it's a big thing, and we're here to celebrate those things. So these are some of the reasons that we're here. And again, our oncology colleagues they really want to know about all of these things as well, but we have to be mindful of having the time and the team sort of assembled to kind of take each of these pieces and put together a plan. We're here to kind of provide that extra layer of support for our having a holistic plan. So we have our cancer treatment plan, but we also want to make sure that all of these other pieces that are incredibly important get addressed. Next slide. If you've been to Massey, you may have seen this, and this is something, so the National Comprehensive Cancer Network is a group that creates a lot of tools that are used in oncology. So this is not something you would just see at Massey, it's something you would see at most cancer centers. And I think this really gets to what I'm referring to when we say it's a lot more than just asking someone who has cancer about their pain. So on the left, you see kind of a typical thermometer, goes from 0 to 10. And realistically, the question there is asking, factor in all of the things that might be causing you distress. What's the total level of distress that you're experiencing that's related to your cancer? And if you look to the right, you'll see a lot of things that may not be completely tied to the cancer that someone may be struggling with. And what we know is if we don't address all of those things, that person is going to continue to have a lot of distress, and that's going to affect their treatment. And that's what we're here for. We want to make sure that we partner with all of our other colleagues to help figure out what these things are, how to improve them, and how to get that person back to having a quality of life and be able to kind of get the treatment that they need for their cancer. Next slide. So when we look at how you accomplish that, remember there's different domains. And I'll be talking a little bit about symptoms. I'm a doctor, so I spend a lot of time on symptoms. But what I know is that our colleagues that do psychosocial support, our social worker colleagues who help us with insurance issues and transportation issues and other things, all of these pieces are necessary to put together a holistic care plan for someone. And not every single patient needs this, right? There's obviously a spectrum of care that we provide here. But for many patients, you'll see varying degrees of these pieces sort of added together for each individual person. And our job then is to figure out what those pieces are and how we can work together to create a plan for that. But we do have to then ask about all of these things. So I showed you the distress thermometer, which is a way of just kind of getting a very quick overview of things. But then it's our job to kind of go through each of these quadrants and really start asking questions about where did that overall level of 8 of distress come from? What are the factors? Which are the ones that are bothering you the most? And how can we help? Next slide. From my perspective, when we look at the physical aspects, we really want to know, yes, we do want to know about pain. We ask a lot about pain. And it's not uncommon for patients who are referred to our clinic to have pain as one of their symptoms. But a lot of times what we find is that although the referral was for pain, there's actually other things that are bothering that person. And actually sometimes some of those other symptoms are more bothersome to the person than the pain is. And I think one thing that we all realize, whether you're a doctor or not, is that if you're suffering from a number of the symptoms on this screen in front of you, even if I get your pain somewhat better, you still have a lot going on. And you're not going to feel as good as you can. And that's what we're here for, right? So part of our role then for every patient we see in our clinic, not just on that first evaluation, but on follow-ups, is how can we get to know all of the things that might be bothering you, make a plan for all of them, and then follow them all over time. Are they getting better? Are we having success? Is there one area that we're kind of stuck in and we need to focus more on because some of these other things have gotten better? And that's sort of what things look like when we take care of patients. It's sort of this initial deep dive into all of the things that are going on, and then we pick certain things to focus on and follow over time and really make sure that we're kind of seeing things improve Maybe sometimes we reprioritize over time. Pain was the initial worst problem, but maybe over time the nausea got worse with treatment. Then we need to change our plan. And that's sort of how we approach at least the symptom management piece of what we do. Next slide, please. So many of you are familiar with the concept of cancer pain, and I do want to identify that there are a lot of resources out there. So if you have questions or want to think more about this topic, there's a lot of great resources out there. This happens to be from the American Cancer Society, but there's a number of organizations that have different resources online that can give you a better idea, not only of ways of managing it, and that can be both with medications and interventions, but also non-pharmacologically or without medications. But it also gives you ways of understanding what our assessments are, how we look at pain, how we assess it over time. And sometimes that makes it a little easier for you to understand what kind of information we might need to know and how we can partner with you to help understand your pain. Next slide. This resource in particular was from the National Cancer Institute. So the NCI is part of the NIH, the NIH National Institutes of Health, which provides a lot of grant funding for studies that are done at Massey. And they have this booklet that they put together, and I have the address at the bottom in case you're interested, that I think does a really great job of summarizing what cancer pain can be like from the perspective of those who have been through it. And again, some of the assessments, some of the team members that we engage to kind of help address some of these things. So I think it's a really good resource. We can go to the next slide. And out of that, I did take this quote because I really liked it. Well, first of all, they mentioned palliative care in there, so I had to put that in there. But they had this quote I thought was great, which was, I thought that I had to live with the pain, but then it got to the point where I just couldn't handle it anymore. My doctor and I talked about it, and he decided to change my medicine. I'm not saying that I'm pain-free, but it's a lot better now. And I think part of, and again, in this role, we might be partnering with the oncologist to treat the pain. But I think the recognition is that a lot of our folks, a lot of our patients think, well, pain is just a part of cancer and it's just something I have to live with. And although we do have to always weigh the risks and benefits of treatments that we pursue for anything that includes pain, it is really important for us to sort of really holistically look at that problem and see what we can offer. And again, it's not always medication or an intervention. There are other things that can sometimes be done that are really helpful for pain that have nothing to do with medications or interventions, and really actually don't have a lot in the way of risk or side effect. So the sort of thing we want to make sure that folks know is that if you're suffering with pain, that there are definitely resources to help. And sometimes that's your oncologist. Sometimes your oncologist is going to be the one to manage it. And if things are maybe a little more complicated, or just to get different recommendations and a little more team support, we might be the ones helping with that. So just more resources to look into if you're interested on that topic, because that does tend to be something we commonly see. But it's definitely something, if you're suffering with it, that there are ways of managing, and we're here to help. Next slide. So I have a bit of an example in here, because sometimes when we talk about globally what we do, it's hard to kind of conceptualize what that looks like. So I have an example. I will tell you, though, that this is not an actual real person. There's a lot of laws that govern using cases of actual real folks. So what this is just sort of a grouping together of characteristics of patients that we generally see. So this isn't one particular person, but it is sort of representative of the folks who get sent in referral to our clinic. So I have in front of you, so we talked about the distress thermometer. You guys are getting great over there at assessing already, right? You have our distress thermometer and we have our symptom assessment scale. And this is not uncommon, right? So this is not any particular patient, but it's not uncommon that the folks that are referred to us tend to be having higher levels of distress. And if you look at that symptom assessment, really tend to be indicating to us, again, that it's, although they were referred for that pain and pain management, that really fatigue, some nausea, maybe some mood issues, boy, my appetite is really bothering me. So it's not just that pain, it's a number of things that are sort of adding together. And all of those things, if you look at that second to last line that says best feeling of well-being, and that one is a little tough to understand the number score on. It turns out that 0 is good and 10 is the worst on this particular scale. But all of these things add together to create this feeling that my well-being, it just overall just isn't what I want it to be. And that's not what we want, right? We need you feeling, you know, if not 100%, closer to 100%. So again, we need to get you into your therapy and doing the things you want to in life. So this is not uncommon to see, and we can go to the next slide. And I think one of the things that I highlighted before, and I'll highlight again here, is that when we do these assessments, we say, okay, there's a piece of this that the patient is having pain. So there's a physician or an APP who's working with us. We're going to take a complete history on that. We're going to figure out what modalities, what things we can use to benefit that pain. But also, there's some family members who really have a lot of questions about some of the pieces of the care. And our nurse navigator is going to go and kind of interface with the different teams that are taking care of that person and get more information so that the family can kind of get a handle on some of the answers that have been kind of, they're not sure of, and would be really helpful. They'd feel a lot more settled if they understood. And the nurse in the clinic, while we're waiting for that physician to come in, is going to sit with the patient and do that symptom assessment. And a lot of times really winds up doing a whole lot of support for someone who might have had a whole list of things going on for a while before they came to see us, and really just wants to get that off their chest and just kind of put that out there. And there are times where our nursing colleagues will spend almost a whole visit's worth of time just kind of working through all of the things that have been going on and providing support along the way. We're really lucky to have a psychologist that works with our team, and I think in the instances where more support is needed, then we can provide with the team members who are in that visit itself. We'll meet with patients and not only kind of assess for other things that might be going on that we could treat, but also provide some therapy support. We're also very indebted to our social work colleagues who help us navigate all the bumps that are along the road with insurance companies and prior authorizations and making sure we can get medications and figuring out home care plans and that sort of thing. So when someone comes to clinic with, you know, that sheet that you saw in front of you previously, it really is a place for all of us to come together, each take our separate piece of this and put something together that's going to be kind of a holistic plan for that quality of life for that person. We can go to the next slide. So, and again, this is an example patient, but again, this is not uncommon within the 2 to 3 months that we're seeing someone in follow-up, that a lot of these things will get better. Now, one thing I will note is that you see that maybe some of these things aren't a 0 now. They're not totally gone. But when folks come back to us and they say, okay, my pain and my appetite and what have you, they're still bothering me, but I can do all my things now. Like, I went from not being able to get off the couch during the day, not being able to go to work, not being able to play with my kids, not being able to, you know, do things around the house, do my gardening that I enjoy. Now I can do all those things. I get a little tired sometimes. Some days my pain's a little worse and I kind of take it easy, but most of the time I can do all these things. That's awesome. That's what we're looking for. And that's what's so important, right? We want to make sure that we put something together. Again, we're treating the cancer, but we're making sure we treat that human. So you can go on and have the quality of life that everyone deserves. I do also want to highlight, and we can hop to the next slide, for a lot of our patients, we also help with if patients are interested in completing legal paperwork that surrounds either having a decision maker appointed or having some ideas on record of what kind of treatments or limits that they might want to think about in the future based upon different scenarios, traumas and accidents and things. We can help with that. Our team manages these processes for the health system, so we have a lot of expertise in it, and can certainly provide advice and help filling out these forms for anyone who is interested. So we can move to the next slide. I do want to tell you just a little bit about our program here in specific. Palliative care, because it's a newer field, when you go from location to location, you're going to see the services be a little different. So if you came from somewhere else, you might actually be used to having a palliative care program that can see you at home. We're still working on that piece here. Those are all kind of a work in progress. But when you go from place to place, you might see different things. So we don't have a home care program right now, but we're in talks to develop it. We do, however, have a palliative care unit, and that is an incredibly powerful tool. The leadership at VCU has always been very supportive of having that resource for patients and families, and we're very grateful for it. In fact, a little later on, I'll show you the anniversary piece that John Wallace and his colleagues kindly wrote from Massey about our program, and really kind of recognizing the amazing benefit of 20 years of having a palliative care unit here to this community, which is really remarkable nationally. Many programs don't have that unit, and certainly if they do, having it running for 20 years continuously is a major milestone and a huge accomplishment. I do want to highlight, though, in addition to the clinical care we provide, there's other pieces to what our program does that are also crucially important, not only for our patients and families here, but for our community. So education is something that is very, very important to us, and that is not only education of our physicians in training who are residents and fellows, medical students, but it's also nursing students, chaplaincy residents, social work interns. There's a number of folks that work with our team, and we all want to learn together how to better communicate, how to assess for symptoms, how to make sure we have cohesive treatment plans. So we do a lot of education in the hospital, and we're thrilled about it. Under service, I did mention we do a lot of the work in the hospital system around helping to support the documents that patients and families create, to make sure that if you've created a document that we're going to honor it here when you present for healthcare. That's still a work in progress as well, but it's very, very important that if you have told us what's important to you, what you want for your healthcare, that we make sure no matter where you present in our health system that you're going to get the healthcare that aligns with what you've documented. I do also have listed on there research. Apparently I've also listed education twice. It's really important to us. Research is something I'm going to talk a little bit about here as we close up in our last few minutes, because I do want to make sure we leave time for questions. When I told you at the beginning that our field is newer than other fields, it is sometimes less likely for us to have that sort of solid foundation of research that you've come to expect in oncology. Oncology is so rich with research, not only in kind of treatment protocols, but in also how you approach diagnosing and how the teams work together. Part of the reason we're so grateful here to be part of Massey is because Massey really pushes everyone who is here to be excited and dedicated about how we get to the future. And we can go to the next slide here. And part of that, as we've had our journey, and this was the article that Massey kindly kind of highlighted some of the work we've been doing, and then we'll talk a little bit about our future work, is sort of that focus on, okay, you're providing great clinical care for our patients, and that's wonderful. But what about the future? What are other things we could be doing? What are the things that haven't been asked about that we should be? And there's so many of them in our field. There's so many opportunities, and we're really grateful to our partners in Massey that, this is an article that's partially about some of the studies I'm going to talk about. But there's more projects that we have coming online, and we're super grateful to our Massey colleagues for supporting the work that we do so we can better explore some of these quality of life pieces. We can go to the next slide. So when we look at this quality of life piece for cancer patients, our colleagues in oncology are working on having all of the studies to look at, again, treatment protocols and chemotherapy regimens that might be the most effective, the next treatment out there that we don't even know about yet for cancer. Our role here and the support that we're given from Massey is making sure what are the symptoms that are really most bothersome to our patients? Do we have solutions to them? What medications can we use? Are there other solutions besides medications that we can use? So we're really being asked to explore, not only can we use what we know about making quality of life better right now, but how do we push the boundaries? How do we figure out what the next thing is going to be that could actually make things even better for our patients? So I have some examples here and we'll walk through them in the last few minutes. But there's a lot of what ifs here. What if we could use technology to help manage symptoms? What does that look like? How do we explore that? What if we knew the best way to manage one of the most challenging syndromes we see in our inpatients in the hospital? What if we had better ways of managing fatigue? Fatigue is a really tricky symptom. What if we had something we could offer to some populations of our patients? What if the struggles with appetite that a lot of folks experience and is super frustrating and really upsetting to families, what if we had better ways of approaching that? Next slide. This is, I know this is a bit of a messy slide, but there was so much fun about this pilot study that we did. So this was a study done in conjunction with the VCU School of Arts. Dr. Ryu, who's there, is one of the arts professors and specializes in avatar and kinetic motion imaging. And she was able to create a program for us, and you can see it on the screen in the middle there, what the avatar looks like and the different backgrounds that she made. And she partnered with us in the clinic setting to be able to bring this avatar intervention in, just to sort of see, first of all, feasibility. Can we actually do this in the clinic setting? Can folks actually put on all the sensors? You see them lit up in green on one of her students who's helping us walk through this. And does it make people feel better? Are there things that that would improve about quality of life based on this? This was a small pilot. It was incredibly well received. Most of the patients who were in it asked if they could do it again, which unfortunately we haven't been able to do yet, but hopefully we'll get there. Obviously you see the publications, but it also won an award internationally for arts and healthcare. So we're hoping to create a larger pilot to really kind of explore, if we think this is something that's feasible to do, how do we get this to be able to be offered, and what symptoms might it be helpful for? So really looking forward to future studies in this. I'm very grateful to the folks who helped us pilot this out and explore whether or not we could feasibly do this. Next slide. And this is a quote from, again, it's actually from various families, pieces of it. When folks are in the hospital, sometimes there's a syndrome called delirium, where it's really hard for folks to be able to think and process and focus. And one thing that we know about this is that there are certain instances where we don't have a lot of guidance on how to treat it. And not only is that really hard then for the patient, but obviously there are loved ones who are sitting there completely helpless on how to take care of their loved one, how to get their loved one back to being able to think clearly and interact and not be agitated. We can go to the next slide. This study was developed in partnership with MD Anderson. I wish Dr. Del Fabro was here tonight. He was supposed to be, but then his plans changed a little bit. He's much more exciting than I am. But he's the principal investigator here for VCU on this study. I have the schema on the right. I wouldn't focus too much on that, except to say that this is a pretty complex study, and I'm really proud of our Massey colleagues for the support they gave to be able to open it here, as well as our unit staff who have been helping us to run this study. Because it really is helping us to learn more about how do we manage this best, and what medications are the best answer for this, and how are we going to use this information for the future. Also grateful to the families and patients who have been a part of this study over time. It's probably going to be about another year or so, and then we'll take our data and MD Anderson's data, and there's an additional site, and really be able to say a lot more on this topic than anybody actually has been able to. I will say that NIH, so you see them at the bottom, their funding is sometimes very hard to get for quality of life type of studies, and we're we're really blessed that Dr. Del Fabro is here and partnered with folks at MD Anderson to be able to kind of create the partnerships that allow for studies like this. Next slide, please. So fatigue is something else that we see very commonly, and it can be frustrating because sometimes there's not medication specifically for it a lot of the time, and there's not other interventions sometimes that patients really feel kind of help them get over that fatigue feeling. We can go to the next slide. So again, Dr. Del Fabro worked on a protocol this time with our colleagues at Harvard and the University of Washington to explore in male patients whether or not testosterone replacement for low testosterone levels actually would help with energy levels. Again, you see a lot of complicated stuff on the screen. I wouldn't focus too much on that. Those are all of the outcomes that they're measuring. He tends to like to do really complicated studies, which is great. We're going to learn a lot from this. But this is the sort of thing that he likes exploring. What are the symptoms that tend to be really hard to treat, that we don't have a lot of great answers for, that really impact the quality of life in our patients, and how can we do better? To that end, we can go to the next slide. The last one, and I don't have any of the schemas for the studies. I think he just closed one and he's working on opening another. But what treatments might there be for low appetite? This is a symptom that's really bothersome to folks, and there's not a whole lot right now. There are various medications that we can try to use, but sometimes they're not effective for everyone. And we really do need to look at other options. So again, Dr. Del Fabro has been working in different areas that really impact quality of life for cancer patients to try to find solutions for how we can get that. If we know we have certain interventions that help with quality of life, how we can do even better in the future. Next slide. So just to sort of put out there as well, I know that Dr. Nguyen, who is the Cancer Center director and is just incredible, has been very much out in the community really talking about what the benefits are to clinical trials. And this is, again, from the NIH's website. But there are benefits to each individual who is participating. So I know that when folks hear that term clinical trial, it might make some people nervous, and why would I think about doing that? Would it expose me to risk? But I do want to highlight, as Dr. Nguyen and others have, that there's a lot of benefits, not only to kind of the community and other patients in science, but also potentially for that individual person. And we can go to the next slide. I do want to highlight for the studies that are in supportive care. Again, all of our studies are based on quality of life or symptom outcomes, and also to highlight for any of our trials that are medication-based, the ones we have open already and the ones that we're looking at, these are all FDA-approved therapies. We are just looking at different indications for them. So they're all known to be safe. Their risk profiles are already known. And realistically, again, this is part of Massey's mission to sort of advance that whole person care. So I do have at the bottom there, if you know someone who has interest in participating in clinical trials for quality of life and may be interested in some of the topics I mentioned, Kendra Rowe, VCUhealth.org, is our research coordinator, and she'd love to kind of hear about your interest and see if anything we have open might match. We can go to the next slide. And this, just to close, so Rennie is our palliative care facility dog. And here in this picture, she's offering a box of tissues to one of our nursing colleagues, which was just the most darling thing. We are very glad to have Rennie back with us. And in fact, that can be one of the more common questions we're asked when we're kind of out in the environment. She unfortunately was not able to be with us all of the pandemic, but she is back now, not only taking care of patients and families, but also all of us on staff. So if all else fails, we all refer to Rennie. So with that, I'll close our slides. Really would love to hear any questions that are out there, and really appreciate everyone participating. Thank you.
It's definitely always a treat to get to see Rennie. So hoping I can pop in and see her soon. Well, thank you very much for that educational presentation, Dr. Noreika. We'll answer some questions.
Perfect.
We'll address the comments in the comment section in a minute, but first we had a few submitted in advance. So first, you definitely touched on this, but it's probably good just to kind of refresh. What's the difference between hospice and palliative care?
Yeah, great question. I think the main difference, remember, hospice was a program that was really designed around the needs of patients who are at very end of life. And it's really meant to allow that care to happen in the home or skilled nursing facility, nursing home setting, and really provide that support in that level. The way Medicare has this defined, it's really meant to be kind of in those last months of life. And again, our specialty grew out of the idea that, well, wait, we don't want to just focus on quality of life in whatever the last few months of life are. We want to focus on quality of life at any point along an illness. So we are free and welcome and paid by insurances to take care of patients at any point along their course. And I think it's really important to kind of know that distinction. We have definitely had patients who did not access palliative care because they didn't understand there was that difference. They thought they might be withheld from therapy or wouldn't get their treatments or other things. None of that happens. We partner all the time with our oncology colleagues, and we work as a team to, again, take care of that whole person. So really here to be kind of a support whenever we can be helpful.
Okay. So, I mean, you've definitely touched on this too, but what does a palliative doctor do that's different from what my other doctors do?
Yeah, that's a great question. And I think one of the things we very much realize is that our patients will sometimes tell us, well, gosh, I have an appointment with my oncology doctor, and then I have radiation treatments, and then I have to go for separate treatments in the infusion center. And there's a lot of appointments now. We absolutely realize that. I think, and a lot of times in recognition of that, we'll really try to work our schedule around times you might already be there, because we get it. There's a lot of burdens to being able to keep up with cancer treatment. I think one of the things that's really important for the care that we provide is that we get to focus on the rest of you. We want your oncologist to focus on that cancer and getting rid of it. Done deal. We want to be we want to be the group that is focused on all the rest of it, though, so that while we're doing that, you're able to maintain your quality of life. We want you spending time with your kids. We want you being able to do what you want to do at work. We want you being able to be in the garden or training for a marathon, whatever it is that your symptoms or other issues with quality of life are keeping you from doing. That's what we want to focus on. And there are times that we spend an entire hour in a visit focusing on all of those pieces. And that's a piece that, and your oncologist absolutely wants to know about all that stuff, 1,000%. The oncologists here are amazing. They all care about all of these things. They don't have the time to devote their attention to what your cancer needs and all of that sometimes. So we're here to be that safety net and partner with them to do that.
Okay, great. Another question. I have a family member receiving palliative care. Mm-hmm. Is it possible to slow down death by taking pain medicine?
Yeah, so I will tell you that pain medication doesn't really, obviously there's other ends of the spectrum where for folks who have problems with pain medications, we have to be mindful that there's risk to that. But truthfully, giving someone pain medication doesn't change anything else about their medical course. The only thing that it changes is hopefully what you're able to do. So the whole goal behind pain medicine is you are used to this level of function, and now you're down here because the pain is just too much for you to be able to sleep, eat, do activities. That's not going to be conducive to you getting the treatment you need. So our goal with the pain medications is to give whatever it is. And again, I'm saying pain medications, it's usually a whole plan that includes other non-medication therapies. But our goal is to give you enough to get you to a point where you can do the things you want to. Pain is still there, tolerable, okay? But the pain medicines themselves don't change anything else about your medical course or care.
Okay.
Good question.
I won't make you completely rehash. You pretty much extensively went into what research is being done in palliative care at Massey.
Please ask more about it. Please ask more.
But if you want to elaborate on some of the research being done, but also maybe touch on, are there clinical trials, and how may I find one at Massey or elsewhere?
That's a great question. I might actually make Blake and Sean Wallace tell us how you would find our palliative care trials at Massey. It's like, darn it, I shouldn't have put this up there. We do want to get the word out there about our trials. I don't think, and we get it. We want the oncology treatment trials, like that's a big area of focus. We want folks to be kind of knowledgeable about that. But for a lot of our patients who really want to participate in clinical trials, if they happen to have some of the symptoms I talked about, we would really love to kind of hear about that, because I think it's always a little challenging sometimes to run these trials. You need to make sure you can accrue enough folks who have, meet that criteria to be able to be included. And it's only when we get a good group of folks that we can actually learn something about that syndrome. So I think, I think actually I'm unaware, so I'll put myself out there for that, of where you might be able to find that kind of on a website or other information that Massey has. But I've listed most of our active current ones. There are a few more that'll probably come along the way in the next 6 months, and certainly happy to hear about ways that we can get the word out there for that.
So I definitely know that clinicaltrials.gov is a good website for finding just national clinical trials. We can definitely share a link to our page in the comments section. And then masseycancercenter.org is our general website that you can search through there too.
Awesome.
Another question, can patients decide to move from palliative care to hospice care, or does the doctor make that decision?
That's a great question. So those sort of decisions are always the patient and their loved ones make. I would really encourage that to be a conversation. If palliative care is following you, we're certainly happy to talk about it, but also with your oncology team, just so we're all understanding kind of if there's, and I say that because I've had folks before ask about hospice, and then once we talked a little bit about their concerns and questions, really we're kind of like, maybe hospice is still in the future. And now that I understand better about kind of where things are. So I do think having our oncology colleagues be aware of things so that they can kind of give any advice, answer any questions, that sort of thing. But it's really up to each individual patient and family to decide what resources and when kind of in the course that might make sense.
Okay. One more question. How can palliative care benefit caregivers?
Oh, I love this question. Great. So I think one of the things that I love about practicing in palliative is that, yes, we take care of the patient, but to us, the patient is more of a unit. And that unit is, and we tend to use the word family. And I think one of the things I would tell you is that I tend to define family as whoever you tell me your people are. And that may or may not be folks that we traditionally describe as family. And that's great, because you're going to tell me who your supports are. Those are the folks who are there. Those are the folks who are kind of in the day-to-day with you, helping kind of fill in and support. And we want to make sure that we, and again, the patient is the boss, right? So we will involve folks as you allow, but we do want those folks to be part of whoever that support team and network is for you. We want them to be a part, certainly, of whatever we're discussing as far as care plan, but we also want to know how we can partner with them to help improve the quality of life. A lot of times caregivers are, and a lot of times when we have patients even on our unit, I'll thank the folks who are at the bedside, because they now are partnering with us to help take care of their loved one, right? I'm able to do a lot with the team that I have and the medications we have access to, but caregivers are a special group of people who are really providing a lot of that care plan. And I think some of the time just being able to involve them in our care plan is something that's really helpful. If you're providing a lot of care, but you're kind of over here and you don't really necessarily understand everything that's going on, you don't have a chance to ask your questions, you don't have a chance to give us your observations. Sometimes when folks come in, they'll kind of tell us about one thing that's happening, and a caregiver that we have an opportunity to talk to will be like, wait, what about this? What about this? What about this? And those are all things that are impacting that person's quality of life we wouldn't have known about. So I think there is benefit in caregivers being able to kind of tell us what's been going on. We are, I think we are working on over time as a sort of a group in Massey on how we can formally provide more support to caregivers. And there's a lot of folks out there. I think Massey is looking into some, I don't know that they're huge trials, but some work around what is the experience of caregivers who are helping with cancer care in Massey patients, and what are the things that would provide them more support. So I think our role is generally to kind of include caregivers in that treatment plan and the discussions about the treatment plan. But I think we are looking for ways on directly providing better support to the caregivers, even aside from the patient encounters.
Okay, great. I think that is it for questions. I don't know if you had anything else you kind of wanted to add.
No, I really appreciate everyone's interest and the great questions. And certainly we're always happy to hear from folks. A lot of times our oncology colleagues are the ones who are asking us for a little help, but you're also welcome to kind of any of the nurse navigators, our oncology colleagues, our oncology nurses. If you think that we can kind of help support your course with your cancer care, we're certainly happy to help do that. So just let the folks who are around you know, and we'll make sure you'll get the support that you need.
Well, Dr. Noreika, it's been such a pleasure having you join us for this discussion. For anyone watching, more information about palliative care for cancer patients, you can follow at VCU Massey Cancer Center on Facebook, or visit Massey Cancer Center at masseycancercenter.org. Once again, thank you, Dr. Noreika, and anyone who joined us. Have a great evening.
Thank you. Take care.